You're listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years of EMS experience. Each month we discuss EMS news, medical science, and review actual EMS calls, offering many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone to the Medic Materials Podcast. My name is Mike Turek. I am joined with Emily, as always, Gerard, and our almost EMT. You should probably know your results.
Halfway there.
Halfway there?
Done with my practical, not with my written.
Yay! See, look at that. So it is December 15th when you guys will
Ladies and gentlemen, Tasmanian Devils, man. How are things down under?
You know, it happens. You know, so it is December 15th, and today's call is going to be tying in our December 1st episode in where we talked all about brand new providers, brand new EMTs, and kind of transitioning into that, you know, great wide world of being on your own in an ambulance, treating for your patients. And the sad part is you guys have absolutely no idea about this call, but the only foreshadowing I can give you is it is our first call from outside of New York State, so that's pretty cool. So this is our first submission from another provider, and it is catastrophic. It's the best word that I can, or as the old guy that I used to work with in the kitchen used to say, unfucking believable. That's more or less what you guys will be thinking when you're hearing this. So
is that equivalent to goddamn ridiculous?
It's no, I think unfucking believable is bigger. I think it's that shit ton to crap ton
to fuck
ton.
Gotcha.
Right? Kind of. I think we're in the fuck ton of bad here.
Gotcha.
Okay? As you guys will see. But a little bit of housekeeping before we jump into it. We've been growing on all of the podcast platforms. Just make sure to keep our growth up. You actually rate and review the podcast. And I see all that, so make sure if you really hate what I say or what we say, let us know and be like, hey, you're douchebags, or hey, we love you, because we take all the all the constructive criticism to heart. So
we know we're douchebags.
It's okay.
Yeah,
it's okay. I know I talk really loud, but it is what it is. So okay. Here is the setting. I want to jump right into this. The setting. You have a small city. Paint the picture.
There it is.
Okay?
Picture
there
this.
It is.
Sicily, 1925.
So there you were in a small city, 10 to 15,000 residents. So it's not terribly huge. Okay. You have a community hospital, just a generalized community hospital, approximately 20 minutes away from where this call occurs. You have a large city hospital, approximately 1 hour away from where this call occurs. Okay. Your crew is a city fire department. You have 2 basic EMTs. For this particular call, there is no ALS response. However, there is ALS nearby within the department if requested. Okay? Keep that in mind. So these 2 basic EMTs in this fire department are dispatched priority 4 or an alpha priority, depending on where you guys are, to a local elderly apartment complex. Okay? Priority 4 is no ALS. That's why medics did not go.
No lights, no sirens.
No lights, no sirens. EMTs should be able to handle it. Whatever. We'll get to that.
Because dispatch is always right.
Because dispatch is always right? But at least that's what they think. So dispatched alpha priority to an elderly apartment complex for an 85-year-old male with altered mental status. So now, in my opinion,
How is that priority 4?
That sounds priority 4 to me.
That totally sounds priority 4, but whatever. We're gonna say the dispatch is high on something, whatever. And they dispatch a priority 4 for these 2 EMTs. When you get there, okay, the crew decides that they're going to bring in, because it's a large apartment complex, they have to leave their truck out front, right? They decide to bring in their stretcher and their first in bag. Do you guys believe for an altered mental status that they need anything more?
First
The
in bag has
wheels are turning
I was going to
already.
say, first in bag, you've got oxygen, stretcher's got oxygen. Right.
You would think. I'm not
delivery
entirely
systems, Right,
Right,
like
we've got
on
our
a typical
basics
first
now.
in bag.
Okay.
I'm okay with that.
Yeah.
Okay. All right. So they bring those two things in. They go into the apartment complex. They find the appropriate place, and they're met at the door by a family member. Okay. They get inside and they see a male lying with his head slightly upright in the living room recliner. Okay. He appears to be in no distress. His eyes are closed, and he does not realize that you're in the room, even though you're talking. What are you guys like? That's a nice scene. Size up for you guys. Where do you want to go from here? Leave it open to the room, because I see the wheels already turning in the room here. Emily's like, how can this get any worse?
Oh, I'm already thinking how worse it can get.
I am
Okay.
too.
I've had the, diabetic emergency, breathing has been confirmed. Then you get there and they're like, he's laying on the bed with his eyes
was
looking straight up
confirmed.
going, those were agonal respirations because he's dead.
Okay, well,
So what
we're
is
not
it?
there.
Right.
We're not there.
I got you, but I mean,
Family's on scene. He's not really responding.
So
when you walk in.
family
Right?
is on scene. Yep, he is not responsive, at least to your presence in the room. You haven't actually touched him at this point yet.
Have you tried talking to him?
So
well, just the fact that he's dead, I mean, general impression would be, I would consider him sick until proven
okay,
otherwise.
so sick, not sick. We're gonna say definitely on the
Sick.
sick
Yeah,
side.
he
We don't
should
know
be.
why, but sure, right? People typically are not meant to be altered, correct? Right? Like, so
And if they're calling, it's not Alzheimer's or anything. That's normal.
right. Okay.
And they don't really, like, if you have strange people in your house and they're talking, you don't just ignore that.
Right.
So
right.
that, there's
And
some-
that's
yeah.
that's
There's
something that
there.
the fact that he doesn't acknowledge the presence
Yeah.
of the family member and or the strangers now in the house with clunky gear,
Right.
a stretcher, noise.
Clearly making weird noises that you're not used to.
Clearly
Right.
there's something going on, right? We have to investigate further. So the EMTs go, "Hey, family, why am I here?" Right? The family tells EMS that they were here 2 days prior to check up on their family member, and they were normal. They were moving around. They weren't sick. They were talking. There was no signs of illness or trouble. Okay? They came in this morning to check on him, and they found him to be very lethargic, very confused, super tired. Didn't even want to get out of the chair. They advise you that he does have a history of dementia, but this confusion today seems worse than typical. Okay? And the family member is really unclear on whether or not, how well they've been taking care of themselves within the last 2 days. So they don't know output or input or anything like that. They don't know if they've been taking meds or eating food or fluids or anything like that. And there's no real evidence within the scene for you to be like, oh, there's, pill bottles everywhere and this, that, the other thing. So we really, what do we want to do in this type of situation? That's not much information other than he was okay and now he's not okay, kind of thing. What's the panel thinking here?
It could be anything. I mean, there's a bunch of different things going through my head.
Okay.
I guess the first thing, they haven't made patient contact yet, right?
No.
So why don't we do
So,
that?
yeah.
Why don't we do
Let's
that?
Because
check
if they're
our
sitting
level
there,
of
maybe they're
consciousness.
not really breathing and they're just kind of
Or
hanging
maybe just
out.
an angry old guy that doesn't want to open his eyes and wake up for anybody.
Yeah, there's.
Or maybe he can answer some questions.
Right.
Like, we need to get more.
We
Or
need
maybe
to
he's
get-
in a full-blown stroke. I mean, who knows?
We
Yeah,
need to
right.
get more info, right?
Right.
So, okay. So they go up and they look at him, and there's no obvious visible trauma anywhere. He is alert to voice commands, okay, directed at him. However, he is very lethargic. As soon as he, as soon as you say, "Hey, dude, wake up," he kind of opens up his eyes and then boom, right back out of it. Okay. When you ask him questions, he is extremely confused. He does not make any sense whatsoever. He's not really able to give you any appropriate answers to any of your questions. His airway is patent. His breathing is shallow and rapid. And there's no active bleeding anywhere that you can notice. His pulse is present, but slightly fast. When you check his skin, it's pale. He's got cool extremities, but a very warm core. There's no blankets, there's no anything like that, and he's dry. That's pretty much the initial exam that these EMTs get. Okay. Sick, not sick?
Sick.
Sick, right? We're thinking sick motherfucker here. What do we want to do for this gentleman as providers? What should these providers be doing in this situation?
Vitals, glucose.
Vitals and glucose. I love that idea. Vitals and glucose. All right, so these guys decide to do vitals and glucose. All right, they're on the ball
guys.
so
Well
far.
done.
It's like, Turk, I said that you thought this was catastrophic.
Right.
We're leaning in that
I'm
direction.
like waiting for that drop.
All right,
The
so
other shoe.
all right, so here's what they find. They put on a pulse ox probe. Cool. Now, granted,
He's cold.
Yeah.
It's
so
That's
cold.
what I was just thinking.
okay, it's cold, and this is not one of the pulse ox probes that, are attached to our life packs or our Zols. These are one of the little alligator clips that like firemen carry in their pockets.
Right, from Walgreens.
Right.
Yeah.
We know that
Go
they are not
Walgreens.
very accurate in the first place. However, they get 86%.
Put him on
Okay.
oxygen.
Now, is that because they're cold? Now, this pulse ox probe does not have a pleth wave, so you can't tell like, oh, hey, is their pleth wave really shitty or not? So they're gonna go, okay, we're gonna do what Kelsey says, place them on oxygen. They place this gentleman on 2 liters nasal cannula, and SATs increase to 91 to 92%. Okay, respiratory rate is 22. Heart rate via the pulse ox is 122 and regular when they feel it. And the blood pressure is noted to be 105/41. Now, this is... Wait.
They're
Kelsey,
taking manuals, right?
no, they didn't. That is given to them by the family member who took it prior to the EMS arrival.
But if they were taking it manually, there still shouldn't be an odd number.
Correct. Here's their...
Or they have a little wrist thingy.
Okay.
I was like, wait.
So this particular crew took the family member's blood pressure cuff, right? So they didn't use the family's blood pressure cuff, but the family reported, hey, prior to you coming, I took the auto cuff that we have that sits on the patient's wrists and spit out 105/41. The EMS crew says, okay, 105/41.
Why didn't they get their own?
Fails to check themselves.
I was gonna say that's
So
strike one.
they never actually take a manual blood pressure on this patient. They just
That's-
assume 105/41. Okay, it's fair, whatever.
Fire
Wait,
department.
time out. Because even if you say that's fair, their map is still too low. Like, they're not
Yeah.
perfusing the brain at that.
Correct.
So it's like, 60-ish, 60. It's below 65. I know
Right.
that.
Yes.
So you can say, like, oh, get a manual, blah, blah. I mean, even if you take that. So say you take that
Mm-hmm.
blood pressure, it's still not okay.
Right. But to 2 basic EMTs that I will say these are new-ish providers, right? These are 6 to 8 month EMTs working on a crew together, right? So is it, to me, it's worse that they don't check a manual blood
Oh,
pressure because
absolutely.
that's all they've been conditioned to. So what kind of training or, to me, laziness have they encountered in the last
months.
6 months to now be like, oh yeah, I'll take that, right? But to the untrained EMT that's not a paramedic, 105/41, hey, it's over 100, okay, I'm
It's
good with that.
barely over
Well, it's right.
100.
Yeah, but-
They don't know map
They-
at this
right, they
point.
don't-
They can't sit
they
there
don't
and go,
teach-
oh, well,
yeah.
that's not a map of 65. They
Right.
don't know that
They're
even
not teaching
exists
basics
anymore.
how to calculate maps. and
Right.
stuff.
They go, oh, it's over 100. Okay, it's slightly low, but it's not 95, right? It's not 85. It's 105. I'm okay with that, right?
Interesting.
So they choose not to do a blood pressure. They also don't take a temperature. They do a blood glucose. It's 281.
So his body's dumping some glucose for something.
The body's dumping glucose for something, and they do a GCS. It comes out as 12. They decide that it's 3 for eyes, 4 for verbal, and 5 for the motor responses. Okay? This is the point where they decide, okay, we're going to move him to the stretcher because we're pretty much done here. We got him on oxygen, we got a blood glucose, we got vital signs. We're going to move them to the stretcher. While they move him to the stretcher, they have to do a lift and move. They notice that he's got a Foley bag attached to the opposite side of the reclining chair or whatever it is. And it's got about 150 mLs of very dark urine. So they throw that in between his legs, burrito, wrap him on the stretcher, and move him downstairs. So with everything that I've given you guys, do we have as a table a differential diagnosis?
Yeah,
Sepsis.
I was going to say
Sepsis via what?
UTI.
UTI,
Yeah.
right?
Septic.
If I'm thinking, okay, this guy is septic. He's got a UTI. He was fine 2 days ago. Maybe he
got
had a
that brown
UTI 2
urine
days
bag.
ago, but he wasn't septic 2 days ago. Right? And the family just didn't know.
Did they ever call for ALS or anything? They're just keeping on their merry way.
They're just keeping
Well, I mean, in
on
all
keeping
fairness,
on.
they think that the blood pressure's okay. They're not concerned with the pulse rate. They don't really care about the blood sugar. So in
And
New
they
York
fixed
State,
the SpO2.
right? In New York, with oxygen, and honestly, if that was the only thing going on, that's fair. It's not the only thing going on.
It's like they're paying attention to the
What they
the
want.
systolic. Right. It's almost like they're
They're paying
selectively
attention to
choosing
what
the
they
vitals.
want, right?
It's
So-
like, oh, I have a systolic of 105.
So
Let's not pay
here's-
attention that
here's
it's 40
some-
diastolic
Right.
Now, hold on.
and that he's tachycardic.
And you are playing into something that I wanted to touch base on, and that's confirmation bias, right? So they're sitting there going, oh, well, this guy looks sick, but we don't want him to be sick, so we're just going to focus in on the things that don't make him sick
And justify it.
and justify it.
Right.
That is a horrible outlook for any
In
type
general,
of patient
yeah.
care, right? You need to be open to the fact that this guy is sick.
Take the whole picture.
Take the whole picture,
I mean,
right?
yeah.
Like,
Even the blood sugar of something. You know, in EMS, you're like, oh, that's fine. We're not going to do anything with that. Well, are they diabetic? Are they
That's what
something
I was
not
going to
being
ask.
a
Are
diabetic?
they
'Cause that's
diabetic?
and
pretty
that's it.
significant.
Family says they are not diabetic.
Yeah, that's
they
There's
have
a
a,
reason
they have
he's
a cardiac
jacked like that,
history.
yeah.
They have the dementia history, and they have some lung history. That's it.
And if you,
That's an issue.
and like I said, even as a basic EMT, if you take that blood pressure and you say, okay, yeah, systolic's 105, great. It's got 3 numbers. We're happy. 41
too low.
for
Is-
diastolic.
too low.
It's low.
So we have hypotension. Oh, his heart rate's 122. We have
Tachycardic.
tachycardia.
And
as a-
hyperglycemic.
And
and
hyperglycemia.
hypoglycemia.
And he's hypoxic.
Right.
Yep.
So
And his respiratory count is above
And
normal.
tachypnic,
you take
yes,
all
exactly.
that into account, and that screams shock to a
It's-
basic EMT.
And what kind of shock? Non-compensated shock
Correct.
because you've lost now mental status,
Yeah.
right? So the
My point is, for a basic EMT, just taking those simple vital signs at face value and not being selective, that is screaming this patient's in shock.
yes, yep. So we have established what this person needs ALS, needs a cardiac monitor, needs a fluid bolus with an IV. Whether they, whichever hospital they go to doesn't really much matter, but they need to call for ALS. Like Kelsey said, has they requested ALS at all? Nope. So here's what they do next. They load the patient into the stretcher. Or
Shove him
they
right in
shove
there.
him right in the
Well,
stretcher.
at least he didn't say we shoved the stretcher into the patient.
I've had that done to
That'd
me
be slightly
before.
amusing, but
That
mostly
was-
painful.
So he's already on the stretcher. Let's take the stretcher and move it into the ambulance. The pulse ox, unbeknownst to the provider, the primary provider, we'll say EMT1 at this point in time,
Okay.
falls off the patient. He doesn't know because there's no monitor to sit there and be like, hey, your pulse ox probe fell off. And once they were in there, he did do one thing. He listened to lung sounds. They were clear. Cool, whatever. Equal all fields. Awesome. Fabulous. Then can anybody guess what this gentleman did? This EMT1
Started to write his chart.
started to write
Are
his
you kidding
chart.
me?
I
Sitting,
thought you were
Wow.
joking.
I thought that
was
was
a
a
joke.
joke. Yeah.
no, I'm being 100% serious. This EMT sat in the captain's chair
Oh my god.
and started to do paperwork. Now, I am one, and I know this is me personally. I will never do other than name, date of birth.
Yeah.
On the way to the hospital.
Absolutely.
Correct.
I am not there to be a
Especially-
patient paperwork provider. I'm
You're
there
there
to
for the
do
patient.
care.
Even if there's nothing to do, talk to them.
Exactly.
The back of the ambulance with a patient in it is no place to write a chart.
Exactly. So they start to transport. EMT 2 gets in the front of the ambulance and
They went to the close to the far hospital.
they go and choose the close hospital.
course.
So they go, we're going to go 20 minutes to the community hospital.
We got Netflix on pause. We
I
gotta
mean,
get
a
back.
community hospital should be able to handle a septic
Right,
patient,
yeah,
though.
there shouldn't be a
I'm
problem.
assuming,
They should.
I don't know specifics,
So
but
this community
typically.
hospital should be. It's
Right.
not like a.
I was
It's
gonna say,
not
this
like
isn't
a
like critical access.
It's
This
not
is-
Right,
critical
right.
access. It's not an urgent care.
It's a general hospital.
It's a general community hospital.
they have inpatient
They
beds, they
have
ICUs.
inpatient. They have a small ICU. They can handle
A septic
a
patient.
septic patient. So they do decide to go to the community hospital, 20-minute drive away. Okay, they start moving. Approximately halfway through their transport, so 10 minutes into their transport time, the EMT in the back, EMT number 1, while writing his chart, because it's what a great EMT does, decides that he needs to look at the patient.
Oh, good choice.
Right?
Great choice, right?
It's only been 10 minutes.
It's only been 10 minutes. And he notices that the patient has become more unresponsive.
Oh, boy.
So at this point in time, they
still
finally
called nobody.
request ALS. Finally request ALS.
But now you're 10 minutes from the hospital.
However, right, they're 10 minutes away from the hospital, give or take a few minutes, right? And they are now outside of their own response district. So they have to get mutual aid coming from another ambulance company that gives ALS service. So what they do is they pull over and they wait for said
No.
ALS
No,
ambulance.
why wouldn't... How long are they waiting for? Like T minus 30 seconds or like
I
T
don't
minus
care.
20
Go.
minutes?
No, you
I don't
keep
even care.
going.
Don't wait.
Oh boy.
Because if it's T minus 30 seconds and you're stopping at the park and ride, fine.
I'm not stopping till
Nope.
I'm not stopping anywhere.
I'm not
So-
stopping until I see you.
If anything, I'm increasing speed.
Yeah, exactly.
Okay.
Chase me.
All right, chase
Catch
me,
me.
right?
Chase me.
We're going.
So-
we're gonna bypass warp and light. We're going to ludicrous speed.
Oh, ludicrous speed. So nope, this crew decides to pull it over and wait approximately 4 minutes.
No.
ALS shows up. Now ALS comes with a transporting ambulance, 1 medic, and an EMT.
Whoa.
Woo. They open up the side door, and the medic goes, "Hey, dude's sitting in a captain's chair," because he's still sitting in the fucking captain's chair,
Wow.
doing his goddamn fucking paperwork
While they're waiting.
while they're waiting. You have a unresponsive patient on your stretcher.
Now he's completely
I would-
unresponsive.
Completely unresponsive. I would think that as a provider, you would be
At least updating vital signs.
Airway.
Airway?
Airway.
You know.
A.
like,
Literally
update
I'm
vital
willing. I was
signs.
gonna say I'm willing to bet that we're still
Anything.
using the family's vital signs at this point.
It's literally A.
No.
None have
No
been taken.
vital signs have been taken through
Yeah.
transport.
That's what I figured.
None. No vital signs through transport. He did.
Once you
paperwork.
get in the cabin's chair, that's it. You're done.
That's it. I've checked out. I'm done. Right? Worst fucking chair. Get it out of there. You can intubate
Yeah.
without it.
Yeah.
I
I've
don't need
never intubated sitting in that fucking seat. Get rid of it.
Yeah.
Right? So, EMT number 1 goes, "Mr. Paramedic, cool. This is the story. He was, alert to voice. Now he's unresponsive."
But now it's been, 15 minutes. He went alert to voice, unresponsive, and you still haven't done anything with the airway.
Correct. Nothing has been done in the airway. Nothing has been done in breathing.
Period.
Nothing's been done. He's got a nasal cannula in. Cool.
A, B, it's right there.
Right. Nothing, right?
Okay.
They did half-ass vital signs. They got a blood glucose. They put him on the stretcher, and they started driving. They noticed that they became fully unresponsive and said, "Ooh, hey, we should probably have some help."
I feel like at this point the family should get paid for this because they did more work.
Right.
Seriously.
They got the vital signs.
They got the vital signs, right?
Go family.
So, paramedic steps in and does an initial exam. Finds the guy to be unresponsive, GCS of 3.
And you get a
Apneic
3 for showing up.
pulses.
Oh, so he's in cardiac arrest.
Oh,
Who knows how long?
And
'cause
how
we
long
don't
has he been in
check.
cardiac arrest?
at
Right.
least 14 minutes.
We don't know. We don't know.
Could be 4 seconds, could be 14 minutes. Who knows?
We don't know.
Okay,
Big
well,
difference for
pushy.
the noodle.
Right?
That's a big difference for your
It's a
brain.
big difference, right? Did this person code 2 minutes after they left?
Who knows?
Did they code 4 minutes ago when they finally noticed that he was unresponsive?
Wait, so when they noticed he was unresponsive, did they check a pulse or no?
No.
They just went,
They just called for ALS.
I need help.
Wow.
Oh, Atlanta.
Yeah.
Now there's no A, B, or C. It's all gone.
It's all
right out
gone.
the window.
Right? So now you have a patient who's in full-blown cardiac arrest in the back of an ambulance with a provider that has an AED, that could have been doing CPR, that could have done an airway, that could have still went to the hospital, and didn't do any of them because they never noticed.
Because they wrote the
Because they
chart.
didn't do a goddamn assessment. Secondary vital signs,
Their job.
their job. They did a part of their job. They did paperwork.
They listened to lunch
They were
sounds.
transporting.
They got the
And they- yeah.
glucose.
So good for them, right? So this paramedic takes over the scene and instructs his EMT, the transporting EMT, the intercept EMT, we'll call that, to start CPR. Tells EMT number 1 in the transport ambulance, you can get the fuck out of your own ambulance. And literally tells that EMT to sit in the front seat and drive them to the hospital. The intercept crew decides to leave their truck on the side of the road, gathers all of their stuff, and transport ensues. While there, CPR is done. Epi, well, let's go in order. CPR is done. IV started. Fluid bolus is given.
I have a question.
Yes.
Now what hospital are they going to?
They're still going to the community
Yeah, now it's
hospital
closest facility.
5 minutes
Yeah.
away. Right? So IV started.
Also, though, the community hospital should still be able to handle this.
Yeah,
Yes.
it's a cardiac arrest.
Yep. This is ACLS at this point.
So I don't
Yeah.
Right?
disagree with that.
Yeah, no, it's the closest facility, and you're already transporting.
And you're already transporting, right? Now it's just get stuff done, right? So IV started, fluids are given, CPR is being done, Epi 1 to 10,000 is given twice during transport, monitors placed, PEA is on the monitor, no shocks are given. Airways established, BVM starts. Once the IV and all that stuff was
Right.
started. Ultimately, they get to the hospital, they run the code for a good half an hour, and there's a negative outcome. So,
Poor old guy.
poor old guy.
I was gonna say, I mean, after
Right.
it's 4 minutes or 5 minutes, anoxic brain injury.
Right, so even if they had gotten something back, it's probably not anything
Life sustaining.
life-sustaining,
Minimal
at that point.
function,
Right.
brain
Right.
function, yeah.
but not even to worry about the outcome. Let's outcome aside. Hearing this call, what are your guys' first thoughts? There's so much to tackle in here, not just of a care perspective, but of
Well, I'm trying not to, I mean, it's easy to, to be critical of them and everything, but I'm just trying to think about, mindset of the crew. Why would you, at some point, somewhere along the road, they decided that,
patient care doesn't matter.
patient care doesn't matter. I mean,
And they're new.
I don't
They're
mean,
6
I don't
to
mean,
8 months into this.
I was
so
gonna say, I don't mean along
They
the
shouldn't
road, like
be
on this
sour
call.
and
I mean,
bitter.
like, right. I mean, I'm talking about like in their careers, they've decided that this is the best I'm gonna do.
But
Right.
maybe they didn't decide that and that's all they know. I mean, if this is,
true, too.
they're that new.
Yeah.
6 to 8 months, you're telling me.
It's
It's
not new.
What if they don't know anything different?
Yeah.
They just think that EMTs get in the back and they write
Right.
their
They
charts.
knew
That's
just
what
enough to be
everybody's done. That's what
just enough to be
everybody
dangerous,
does.
yeah.
And that's why I laugh when you say the paramedic kicked the initial EMT out. But like, you shouldn't. Take
That
that
would've
as a
been
learning
right.
opportunity. Show him what he did wrong. Show him what he could do to improve. Show him why it was wrong. Don't. What's it
Tell
going
him
to
to
change
start
now? All he's
bagging.
going to think is, oh, the paramedics are assholes.
That's true.
It is true. I look at it as I think I think this paramedic was more of the flabbergasted, how do you
I'm
have
sure.
a fucking
I'm
cardiac
sure.
arrest here in front of you and you're doing fucking nothing?
Right.
Get the fuck out.
Oh, I'm sure. Get out of
Then,
my way. Let me fix
hey,
this. Right.
I want to make this a teaching opportunity.
Right.
And I agree. I think
get it,
I
but-
think
Sometimes
you're
yeah.
you're 100% accurate. It is a place of teaching at that point in time. If anything, don't take your don't take your intercept EMT.
Right.
Make
Take him.
make the
him do it.
transporting EMT do everything.
Then he knows.
then he
Right.
at least sees stuff and is like, "Wow, I feel like an asshole because I'm a dumbass."
And I was gonna say,
Exactly,
and even if you're in that, if you're in douchebag mode as the paramedic, for no other reason than a punitive reason. Here, you're the one doing pushy on your patient that you let die.
Which sidebar? I think the paramedic has every right to be a douchebag.
Oh no,
in this
absolutely.
situation.
yeah.
That's what I'm saying.
know, But I agree. Yeah, make him.
Yeah, I
fucking
walk
do all
in
the
and
hard
you're
work.
just sitting there. No. You can start pumping them out, dude.
Yep.
Yeah.
But again, I mean, if I was the medic, how much do I even trust this EMT to be able to do their job, let alone now do pushy? I mean,
Well, because you don't even know them. You're from
Right.
different district, different.
they've never worked together. They're from different districts.
They don't even know each other's names, probably.
Right? And here you are being gifted a dead guy on a stretcher
When the
that-
EMT didn't even know.
Right?
So he's been dead for how
You know?
long?
Exactly. We don't fucking know. Right? There's so many things in this, and I think I don't want to just be punitive on the 80 million things that this both crew did fucking poorly. Because I think anyone listening would sit there and be like, "Oh my fucking Jesus. Wow.
Does this really exist?"
That was bad," right? As we said, catastrophically bad.
Yeah.
But I think we have to attack, how did they get there, right? 6 to 8 months after getting your card,
You should be rocking the house.
you should be, you can suck, but you're wanting to do stuff. You're wanting
Right.
to do assessments.
still
At least
motivated.
you're still motivated.
Right.
This isn't
Not
the
This is-
sour
this
this
yet.
isn't the 35-year-old
That- yeah.
paramedic.
Yeah, no,
that-
honestly, as you were reading it through, I totally forgot about that whole part about this being they're only 6 months out of EMT
Both
school.
of them.
Both of
And
them. This is
Yeah.
a
Because
a
this-
fairly new crew.
Because
I don't know
this to
about
me
you, but
sounded
I'm
like-
excited to witness. No, that sounds
That's a
awful to say. I'm
terrible way to say it.
excited to
Well, no,
witness a cardiac
this
arrest.
to me
but
sounded
I'd be
like
excited to be a
something
part
that
of that.
that somebody who's just sick and tired of their job and is just phoning it in would do
Right.
after God knows how
That's why
many
it
years.
makes me wonder how many times has this EMT one that's in the back
Right.
seen a BLS call go in and they just sit there and write a chart.
Right.
And there are agencies out there that do not allow, it's like, oh, this is ALS.
Right, it
even
goes
though
back
it's
to what we're talking
BLS,
about. Yeah.
And they do sit and write a chart,
Yeah,
and
so
they're
maybe
not
for
allowed
6
to
months,
do
all
anything.
they've done are
Right, and they don't
shucks.
know any different.
Right, and all they know is, okay, I have a patient in the back. That means I write my chart because I have to get ready for my next one.
So
Right.
then what kind of disservice are we doing as
Well,
an
it's exactly,
industry?
and that's what we've talked about before.
Yeah.
It's like, oh dear, we are
We beat the EMT out of the EMT.
We're literally
Right.
training these people
To write charts.
to do nothing, right? To sit there and just
Lift
shuck
right and
people.
drive.
Right. So, is it the fault of their own? Maybe. We've talked about it too. You only get out what you put into this industry. If you don't want to be better, you're never going to get better just by, oh, I'm better. Like that doesn't happen. You have to try and make yourself better. I think where it loses me the most is that they didn't notice that this person was sick in the first place. That scares me. Like, okay, fine. You want to be whatever and sit in the back and write a chart and not do an assessment. There's that to unpack. But not looking at it as a clinical, in the clinical fashion and going, hey, we have a sick human being in front of me. What am I
Help
going to
them.
do to make this better? I feel like, we're going to talk next month all about humanity. I think humanity was thrown right out the window in this. It's like, oh, sick guy. Okay, let's just shuck him to the hospital.
Well, here, I'll be
it's
his
their
Uber
problem.
for the...
Or or like I said, or you said before, the they didn't want him to be sick.
Right.
They wanted him
to be fine.
a nice, easy BLS transport to the hospital where I can write my chart.
Which
Oh, look,
why?
those vitals look good to me. You know, hey,
And-
let's go.
Right.
Why?
But why? Yeah.
But that's my point. I think
Coming from an EMT, if it's an ALS call and I have to sit in the back, that's even easier for me. So like, if you're playing on that aspect, like why?
I don't think he's.
It doesn't
I don't think
benefit
he's
them.
playing on the aspect. I think he's
You don't have
more
to write
just
the chart
saying,
then.
looking at it through confirmation bias. I think they went in there going, okay, it's an old guy at his house with family. He's got dementia. He's already confused normally. He's confused a little bit more. It's probably just the dementia. The family's not here every day to see
how many
it.
times do we hear people use TMB? Oh, it's too many birthdays.
It's
That kind of
What?
stuff.
I've never heard that.
You never heard too many birthdays?
I have.
No, I have not.
Oh, really?
I definitely.
Now you have.
No, I'm gonna use it.
And apparently everybody else has too. Great. Now I'm the douchebag.
No, I've heard it. I'm pretty sure your husband taught it to me, actually.
Well, I'm pretty sure you probably see my husband more than I do at this point
That's
in my life.
also very accurate.
Oh, yeah.
Probably.
I definitely think there is something to be said about, they're looking, they are going in this looking for a zebra.
Yeah.
And they see a cow in front of them, and they're going to paint that cow to
Right.
look like a fucking zebra as best they can to make it fit.
Fitting it what they want, right?
Right.
And I think that's where, why do I need to get another set of vitals? This one sounds
It was
good.
already
And I-
great.
Right? It's
And I-
already there. The fact that they didn't get another
And
one.
it actually makes sense because when you bring in the fact that they're only 6 months out, there's no confidence. They've got no experience to fall back on. They've got no confidence in themselves. So they are hoping and praying that this is just going to be a mundane, easy
But
call.
I think that the first part that they went wrong and their biggest issue was that they didn't recognize that he's sick at first. Because
I
if
agree.
you have a truly non-sick patient, I'm not getting vitals every 5 minutes.
Right.
So they were only 10 minutes out. I would be getting vitals right around the 10, 15 minute mark. So the fact that they didn't recognize that they're sick is where they went wrong.
Mm-hmm. And I 100% agree. This was, with everything.
the fact that they didn't even get their own baseline vitals. is where they went
Also wrong, yes.
Holy
Also
Jesus.
wrong. Because
Yeah.
I guarantee you that auto cuff spit out a hypertensive mark, and this guy was probably like 80s
yeah,
over
he was
whatever if
way
you actually
far-
took a
I
manual.
guarantee he was lower than that, yeah.
Right? So, I mean, assumption crew here, but we all know how non-accurate those wrist auto cuffs
And
are.
every other vital sign fit into the sepsis, the perfect sepsis patient if you
Right.
picture it. So why wouldn't they be?
Exactly.
I was checking off the freaking 5 boxes, and I was like, yeah.
And you
Yeah.
only need 2.
And that's
you
it.
only need in New York State where we practice.
3.
They tell you to recognize
3.
3. They tell you to
3 or
recognize 3 or more. They're tachypnic, they're tachycardic, they're hypoxic, and they're hyperglycemic.
And they have
That's
altered mental
4.
status.
5.
Like, they literally tick off every single box.
Besides the hypotension.
Right. It's like,
And even that number, just looking at it, you're like, that doesn't seem right.
not for this type of patient. But again, that's where I think experience comes into it. The
Yeah.
confirmation
Yeah.
bias comes into it.
I'm trying to, like I said,
You know-
I'm trying to put myself in, as a 6-month EMT, if I'm just riding with another EMT who is about the same level as I am, so I'm not with, a super experienced guy, I'm not with a veteran. It's just, we're 2 kids straight out of the box. And, if you're not used to doing real calls and you're just doing a lot of, the BS shucks and stuff like that, and then all of a sudden you're presented with something that, is a legit call. Right? They, like you said, all roads lead back to we didn't know what we were even looking at.
But
Right,
hold on. I
exactly.
also, another way to look at this in terms that we have all seen in this room is think about when a cardiac arrest happens in an urgent care, right? The urgent care people don't see that stuff. They see the slight difficulty breathing that they can
Right.
fix with an albuterol treatment. They see, a stubbed toe or a broken arm that they can fix.
Right, and you get there and there's
Easy
5
willy-nilly.
people
Kid
running
that
around in a
needs-
circle doing nothing.
Right. And
Yeah.
then, boom, someone comes in with chest pain and codes in front of them, and they're like, blah, 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 I don't fucking know what
Yeah.
to do.
No.
It's almost the same
It
concept
is.
in that maybe you're right. I don't know this agency at all. So I don't know if they do transports. I don't know if they're 911 only. I don't know. So to sit there and go, oh, hey, they might be so green, who knows? Maybe.
But even if they're 6 months out, who's to say that they've seen a septic patient?
Well,
Right.
and that's it.
So even if you're not in the mindset of
Right.
like, oh, I'm just here to, watch you to the hospital or to wherever because we're doing non-emergency transfers, take that out of it. Even if they only do 911, they potentially have never seen a septic patient. They have no idea.
Right.
Not a clue.
That is very accurate, So I think, what comes out of this discussion is that piggybacking on new providers really having to sit there and understand, like, hey, I need to be busy. I need to see calls. I need to do calls. I need to see patients.
Right.
And
I
ask
can't
questions.
I can't just.
It's like I told Kelsey yesterday. I said, what was the one thing you didn't do on the lady that we picked up the floor? Oh, I didn't listen to lung sounds.
Mhm.
Right. Listen to lung sounds every time you get in contact with a patient. I don't care if it's a transfer or whatever, because you're going to hear clear lung sounds.
Right.
So that way, the one time when they're not clear, you're going to go, hey, that doesn't sound clear.
That's
Right.
not right. I don't know
Right.
what that is.
I don't know what it is, but it ain't right.
That ain't it.
Right.
And that's it. Take the opportunities to do calls and do everything.
Yeah.
Like the fact that these guys chose not to do a blood pressure and then maybe didn't get to the second one, but still,
But they
like,
never took
So,
the first one.
I
you
think
never took the first
Yeah.
one, and you never took the opportunity to sit beside your patient and do a secondary.
Try to
Listen to lung
engage the
sounds
patient.
again. Just talk to
Right,
them. Like
you
you
can't-
said, sometimes all you have to do is just talk to
You
them.
can't engage somebody from behind them.
Especially,
Well, no. I'm not going there. Nope. Nope, filters engaged.
Kelsey, you seem like you want to say
Okay,
something.
the one
here.
thing that bothers me the most is, like, even if they had never seen a septic patient, they're 6 months out. They should still have those sheets memorized that they learned in EMT class. Go through it.
Mm-hmm.
Airway, breathing, circulation, okay, that's done. You try to get your OPQRST and your sample from the family. Vital signs and a secondary assessment. You missed both of those. You just failed.
They missed everything.
They missed
ABC from the
literally.
get-go.
They literally missed everything. But that's the thing. If you're 6 months out, even if you've never seen a septic patient, go through your freaking sheet.
I think that 6 month period, I don't know if it's exactly the 6 month, but just that first, sometime within that first year seems to always be, or at least it was for me, was where you're trying to find
Your rhythm.
the rhythm of how it really is in the real
Yes,
world.
you're transitioning from school
from the
Right,
sheets.
from
to
just
real.
memorizing the sheets
Right.
to like an actual patient assessment
Right.
and how it works for me.
You're
I
still
agree.
you're still actually running OPQRST in your head, going, okay, I asked those.
Those
What's
on
next? And you're doing
Right.
it in your head so you don't forget
And
shit.
then there's that period of just pure confusion where you're making the transition to being a decent EMT, where now you're going to get all that information through conversation versus oh.
P.
Hey, wait,
it's
wait,
very
there's no
true.
Q because there's no pain. Wait, what do I do?
Right.
So maybe they were both in that weird transition period. And it was just kind of like a perfect storm of
Or
just
like, oh fuck, my patient's not talking. How the fuck am I supposed to get OPQRST?
right.
And that's another.
Oh, but
thing,
I got
you know,
sample from the family, so
Yeah.
hey,
Kelsey,
So it must be
how
I'm
many-
gonna write my
because that's
chart.
the only information I have.
Right.
That's
But-
what I'm going to go with.
But really, you really bring up a really good point in the fact that, Kelsey, how many unresponsive or semi-responsive medical patients have you done
In
in
class.
EMT class?
Yep.
In class?
Scenario. In scenario.
In class medical, none.
None.
I've done
We
maybe.
don't practice
I've done.
how to communicate with someone who can't
Or
communicate
that's
back.
like the first time that one of the people in my class had a responsive trauma patient. They were like,
Right, because all your
All
traumas
your
are
trauma
unresponsive
patients
and
are
all
un-
your medicals are responsive.
Right.
yeah.
So how much of a disservice are we doing in EMT class? Because that's the training that you're going to fall back on, right? That's the foundation we're gifting you to go out and do this. So they might not have known how to communicate with somebody who was unresponsive.
Right, I was like with the couple of trauma assessments that you actually had, real trauma patients. I remember telling her, hey, don't just grab their arm and start feeling on it. Talk to them. Tell
I'm
them what
always
you're
using
doing.
a mannequin, so I'm
Right.
always just like,
Right.
Right, because you're just going to start
head
grabbing
to
on
toe.
somebody. They're going to be like, what the fuck? Why are you touching me? You know?
It's very true.
So, yeah.
You know, there's definitely something to be said about maybe they just this could have been fucking George Clooney's perfect
Yeah, just
storm.
that perfect storm, yeah.
You know, and everything just kind of worked out to a really terrible outcome that most likely could have been prevented if they got
They got vital signs.
You know, and
Or
that's
trained
the big one.
differently even.
You know,
let's
and that's the thing.
Let's just say they got vital signs, and let's say they came up with the same ones,
No, but
or something similar. Let's say that auto cuff was bang on, dead on balls accurate.
Yep.
Right? Industry term. And, you know, and they would have still done the same thing. They would have said, okay, I have a patient that isn't really.
Let's say the vitals were 90 on 50. Would they have done anything different?
Exactly. Yeah. Would they?
I'd probably hopefully
that's
called
the
for
thing.
ALS
They would have
sooner.
said, hey, 90 systolic. That's not too far off of 120. So, hey.
But you know, here's my I guess disadvantage of being a 13-year provider is I can't remember knowing nothing. So I can't remember. It's true. I can't remember what it was like as a brand
The
new
humble Michael Turek, ladies and gentlemen.
It's so true though. Like, and I tell people all the time, I'm like, listen, I don't remember what it was like to be 6 months out. I remember certain times and places where I had that.
I get
like,
it. I'm at that
oh
point.
yeah, you know.
Yeah, I'm at
but
that
I
point
don't
now where it's
remember knowing
becoming a fuzzy
nothing.
memory. Yeah.
I currently know nothing.
I wish that I could remember being in your fuzzy happy place of knowing nothing. So it's hard for me to sit there and go, okay, well, what would I do if I knew nothing?
I would fall back
if
on
I
my
didn't
sheets.
know nothing, I would fall back on my sheets,
But
or
you've
maybe
never
I would
done
just
that
do
with a
nothing.
sheet, though. Like, you've never
You know?
had you can't get sample and OPQRST from an unresponsive patient.
No, but I could have done ABCs.
Right, but, like, you're going to fall back on your sheets, and, like, in their mind, the ABCs were fine.
Yep.
Yeah. He's breathing.
They put him on
and really-
oxygen.
There's no airway
so now they
compromise.
fixed the problem. They don't think to, like, go back and reassess it.
Yep.
Hey, the oxygen went up into the 90s.
Right.
We're
Right.
good.
We fixed him.
Right.
Yeah.
Our pulse ox is off, though, at some point.
The pulse ox
No, it is, but,
off,
like, in
but
their mind, they had already done that. They checked that box. They
Right.
just never circled back around.
there was no reassessment
Right.
after, like, do your ABCs.
Yeah.
And then once
Follow
you
the
do
sheet. At the
everything,
end of the sheet, what's
okay,
the
look,
last thing? How often do you
Reassess.
reassess?
How
Yeah.
often, and what are you reassessing?
And-
One of the
that's
things
it.
that I keep coming back to this on too is that they never asked questions, and like I realized they got kicked out of their own ambulance, which I'm sure is like infuriating, embarrassing, whatever. I
think
can
it's fucking
understand.
hilarious, actually.
I laugh.
Yeah, but if that was you, you'd be like,
I
Oh, I'd be fucking
Well,
fuming if
I'm
I
not,
was that.
hold on. You technically you did do that to somebody too.
I understand.
That's for a different podcast.
But I understand what it's like to go into a situation and not know. Like, I'm a new nursing graduate. So I understand when they're like, can you get me this? And I look at you like, what the fuck is that?
Right.
Speak English.
Mm-hmm.
And they're like, okay, just go over here and I'll have somebody else do it. No, I want to do it. You have to tell me what it is.
Right.
So I'm a little more upfront and I'm like, fuck off. I want to do it. I'm going to do it. But for them, they're just going to follow what the medic says. And
Right.
they're
Right.
never going to learn from this situation either.
Well, yeah,
That's-
because when
yeah.
somebody yells at you to get out of the ambulance, how quickly you're going to be like, no.
For
And
me,
it-
but
yeah.
if I was them, think back to my younger days, like I would be like, okay, I'm so sorry,
Right.
That's
and
true.
like run.
Yeah,
I
that's true.
That's true.
Definitely
very
would have
different
ran.
now.
Yeah.
I would have loved if I had done that to Emily. She'd be like, "Go fuck yourself."
Now,
But I,
Yeah, but 6 months when you got your
Well,
year,
you-
you
get out of my
go.
ambulance.
But I mean, not too long ago, I can still remember, those first few months of, what it was actually like. And yeah, no, as the time goes by, those memories are getting fuzzier
You
and
and
fuzzier.
Farmers
I mean, yeah.
Yeah, and it's like, so I mean, doing stuff like this is, it's forcing me to try to remember, call it empathy, whatever you want. I'm trying to figure out why these kids did what they did.
Yeah.
And was I ever in a position where it was like that too?
Mm-hmm.
And I can tell you, there were times where I felt completely just, I am shit fucked in over my head.
So,
And-
do you feel like maybe that could have been it, in that they saw a sick patient? Maybe they go, okay, they're super sick. We've done what we can because EMTs give oxygen and problems solve
And the hospital's going to
themselves.
save me because
And
I just got to keep them alive till we get there.
Right. And
Fail.
and maybe I step back and not do anything and hope.
Maybe
You know?
it's just me because I'm like a nervous person when it comes up. But like, I'd be asking that guy 30 times a minute, "Are you feeling any different, sir? You there?" Like, but that might just be my personality,
and it-
where I'd be too nervous if
and
it was
here-
something
here-
I'd never seen before.
Yeah, that too. And here's another aspect that, what's this agency's just operating system like? I mean,
Mm-hmm.
do they encourage their EMTs to, hey, if you can't handle it, call for backup.
Right.
You know, you'll have somebody. We'll get you somebody there. You know, Ricky Tick. Or is it, hey, you know, you guys are on your own. You're in a BLS, bullshit bus. You know,
Right.
fuck off. Have a good day.
And there was a lot of times, going back in my old career when I worked city EMS, you didn't get a medic on everything. I wrote in BLS strokes. I wrote in BLS MIs.
I mean, because
you're not getting a medic, and you're just it's a mile to 2 hospitals. Just drive there.
Right. Is that like the mindset or the corporate culture of that particular agency?
Right. It very well could be. And the last thing that I want to touch on before I go around the table is the fact that they waited for ALS for 4 minutes. Right? Emily's like,
it's my biggest pet peeve.
Like, you're 10 minutes away.
Just
you wait 4 minutes. You can be there. Like,
now that they're unresponsive,
because in 4 minutes,
drive
you're
faster.
still going to be 10 minutes away.
Exactly.
Yeah, exactly.
Whereas in 4 minutes, you could be 6 minutes away.
Exactly. And I think waiting didn't do anybody justice.
No.
Even if they had just said, "Oh, hey, they're unresponsive. Let's just keep driving."
Right.
Let's
And
drive faster.
never picked up on the fact that they were apneic and pulseless. And then they walk into the ER and go, "Hey, we have an unresponsive person." And they go, "Well, they're apneic and pulseless," and start CPR there. At least they're there sooner.
Right.
4 minutes is because then you also have a minute or two to get a report and do an assessment. So you're there for like 6 to 7 minutes.
You're not just there for 4 minutes. Yeah.
You're
Your brain is dead.
Right.
the noodle's gone.
The noodle's gone. Right. So I think that was a big teaching point too, is if you are so close to a hospital, just keep going.
Yeah.
Don't always just be like, "Oh, I got to wait for a paramedic."
No.
Well, that's just it. It's called an intercept.
Right.
What does the word intercept mean? You're meeting at a point. That shaves off time. It's not.
Right.
But don't sit and wait at said point.
Right.
Right.
It's I've reached the intercept point. They're not here. We're stopping. No, we're gonna keep going.
no,
you
keep going.
figure out a way to intercept with me.
Right. Whether that be
Right.
in front or back or whatever. I mean, there's been plenty of times where, before I was a medic, I'd intercept. "Oh, hey, where's my intercept unit? I'm, 2 miles close to the point." "Oh, they're like 4 miles behind me." All right, well, they can either catch me
Or I'll see you at the hospital.
or I'll just keep going and try and find someone ahead of me.
Yeah.
Catch me if you can.
Sorry.
I can't tell you how many times I've gotten yelled at because my intercept will catch me in the hospital parking lot, and they're like, "Why didn't you stop? I was behind you the whole time." I'm like, "But you weren't in front of me."
Right.
Yeah.
So
That's true.
Yeah.
Sorry.
Perfect way of looking at it. So to wrap it up, because I don't think we need to.
It's like, don't you know the pit maneuver? I mean,
I don't think we need to really, beat down this one too terribly. Was there anything that you guys wanted to talk about that you guys noticed that maybe we haven't beat down in this episode yet? The wheels are turning.
yeah.
Just don't write your chart in the back.
God, please don't.
Yeah,
I fucking
I
can't
hope
stand
that
it. It's a
these-
pet peeve of mine.
I hope these providers are still practicing, and I would love to do a call with them to see how much they've improved. And I would love to see in 10 years, if they still practice, what they think of this call.
Yeah.
Mm-hmm.
I mean, I'm thinking doing inter facilities and stuff. They give us the iPads for the back and all this.
Put it down. Leave it in the front.
Honestly, yeah, I get stuck with a stack of charts to do. At the end of a busy day, I'll sit there and I'll have like 2 or 3 to write. But that's because I didn't sit in the back, even on an inter facility. I didn't sit in the back and write my chart. I may have started it and just put some of the quick particulars in just to get it going, but then I put the damn thing down. I'm there to be with a patient. I'm not there to write on a freaking iPad.
Right, and that's it.
If I have a third writer or something, here you go. Start the chart. Go for it.
Right. I was trained to write a chart, but I was not trained to write a chart in front of a person.
Right.
It's not my job to sit there and go, "Oh, hey, if you need me, just holler like I'm your waiter. I'm going to be here buried in my computer."
Can you imagine being a
Fuck
patient
that.
on potentially the worst day of your life, and you look over and the person that is supposed to be helping you
Is buried in a computer.
is on a fucking tablet?
Yeah.
I know.
And doesn't give a lick about you.
Yeah, no, absolutely not.
No. Drives me bonkers.
To me, it is the equivalent of what they force us to do with the whole asking for your insurance information of patients. You know what I mean? Last I went to my doctor don't come out and say, "Hey, while I'm in here with you, you got your insurance card?"
Right.
No, they have the billing people do that.
Yep.
The care provider doesn't do it. We're the only ones who do it. And that's messed up. I'm sorry, I had to go off on that tangent. But that's complete fucking bullshit.
It is complete bullshit.
Yeah.
I agree. And especially at times where you're like, oh yeah, I know I just worked this code on your husband.
Right.
And I know they're dead.
Yeah, can I have your insurance?
Can I have your insurance info? Because we're still going to bill you for this, but we need it now.
Right.
Because you're really an emotional train wreck right now.
But I need you to
your
sign.
fucking shit and then sign here. Press R, please.
Yeah, put yours on there too, just in case you go into a risk.
Right.
Because your grief.
Fuck off.
Right.
Yeah,
I know.
I'm totally with you.
No,
I'm 100% on that tangent.
It is such bullshit. I mean,
it makes us look very professional as an industry. Fuck off.
I don't need my patient going, does he care more about me or care more about how he's getting paid for this?
Right.
Exactly.
Yep. Especially,
I didn't mean to go down that rabbit hole, but
it's a good rabbit hole.
I hate that fucking rabbit hole.
It's a really good rabbit hole to go down.
I'd like to drop a freaking stick of dynamite down there.
Nice C4. Yeah. Anything else? No? Yes? Cool.
Good.
I think.
Yeah, I think we covered it.
I look at this and yes, I say it's catastrophic, mostly because there's so much that could have been done to maybe mitigate an outcome. But talking about what we did, there's a lot of ifs and assumptions and maybe, we nailed some on the head and maybe, others are just complete speculation.
Well,
it's really good for other providers to start thinking about their own practices. Like, this does not happen frequently.
Right. This is not.
This is the only time in 13 years that I've ever heard of a story like this. And it's like, oh, okay, well, how am I practicing? Am I paying attention as good as I'm supposed to be? And I think that's the big takeaway. Yes, could they have seen the sepsis? Sure. Could they have done things to mitigate the outcome? Sure.
Well, that's where I was going to go with my question for the table is, let's say they did call for a paramedic early, and they're riding to an intercept. He coded somewhere within that 10 minutes of them leaving the house. What could we have done, or what would we have done that would have stopped that process from happening?
Well, and that's it. I don't think there is anything.
Is there anything definitively that says we would have stopped it?
No.
It might have just been an inevitable. But the fact that they didn't do their due diligence is the crux of it. But I'm just saying, even if we were on board, it would be like, okay, I'd start my fluids. We're going to start that stuff, and then
right.
And is he already too far to the point where his body's done?
And I think that is a valid point in that I'm the paramedic that shows up. Right? Whether it be intercept, they call me on scene, I'm able to get there beforehand. I'm going to start a line. I'm going to put him on the monitor. I'm going to give him fluids. I'm going to do a temperature. I'm going to get a blood pressure. I'm going to get all that so we can actually see where he's at.
Right.
But I think it's the monitoring
right.
that...
And honestly, in this case, I definitely would have had a 12 lead too, so we would have been seeing some more of the metabolic stuff going on, yeah.
Right. So I think if your due diligence was done and you actually sit there and go, I'm going to watch this guy, right? Oh, I see his mental status declining. Now I can go, hey, I see his mental status declining because he was voiced. Now he's unresponsive. There's that whole,
10 minutes
in between that we have no idea. Did he flip a switch like that and go unresponsive, or was it a steady decline?
Yeah, and I guess my point was, is there really anything that we would have done that could have definitively prevented it from happening?
I don't think so.
No, but the fact that us being there, maybe we would have had a better outcome.
I think
after it happened.
we would have seen it earlier because he's in PEA when this paramedic finally puts the pads
which we
and
know
stuff
from
on.
hypoxia.
And we know from previous episodes, PEA is secondary in cardiac arrest to hypoxia, right? Prolonged hypoxia typically causes the first rhythm to be PEA. So Kelsey said 100 times, hey, this guy's noodle's not perfusing. How long has it not been perfusing, right? Yeah, he's getting passive oxygenation, but it's not making its way to the brain if the heart's not pumping. So, I definitely think due diligence is where we need to leave it, could there be a better outcome? Sure. Who knows? It is what it is at this point.
We'll never know because they never made those decisions.
Right. And that's it. And it really shows how simple decision making can really, flow a call one way or the other.
Okay. I have
you
a
got
question for you guys.
Okay.
So, if you based on the fact that 6 months they've never seen anything like this, wouldn't even know a sepsis patient if they were standing in a crowd with their hand up in the air. Okay. For every new EMT who just tested out, is about to test out, what advice do you have for everybody who goes on that call and they have no idea what they're looking at?
Assess your patient.
I think it's more than that. I think so. The best thing that I can do and give advice in this type of situation is if it doesn't look right, it's probably not. Right? So if this guy does not look right, like if you walk in and you're like, yeah, you don't look right, it's probably not right. There are times.
If your spider senses are tingling, there's a reason.
But you don't have any when you're new.
That is true.
You don't have.
But you do. You can walk in
and be like,
and
should
see
not be that
somebody
color.
and be like, that don't feel right. Like, here's a guy.
I get what she's saying, though.
But what if their spidey senses
they
go up?
they haven't built the spidey senses of.
I feel like
think
you
there's
have an internal, like.
They're not that strong, though, because you really don't trust your internal spidey senses right
My advice
out.
to you would be to take all the information
There's
and
still
don't find an excuse for it. He's altered. Oh, it must be dementia. What if it's not? Just because you have dementia doesn't mean you can't have sepsis,
something going on,
stroke.
Right.
So don't put an answer to it.
Just
take it for what it is.
And I think that's the confirmation bias.
Yeah,
don't go in going, well, this is what it is, and then trying to make it so it is. Go in going, I have no fucking idea what this is. And then be like, oh, this is what's popping out at me the most.
Right.
I'm going to go in that direction.
But still, as a Padawan in Star Wars terms, so he can understand. I know you don't understand. But
I
for him to understand.
I got you.
So these are young Padawans.
Yep.
So what the young Padawan should do is do your textbook assessment, gather all the data, get all that information, and if you looking at the patient, looking at the data, and you're going, I don't know what the fuck I'm looking at, pick up the phone and call the Jedi.
It's true.
You have a phone.
No, he's 100% accurate.
But that's what I'm saying is you could be in that situation.
So
We've totally
I think I kind of get the point.
excised her from the conversation.
I don't understand Star Wars.
he just said call a doc.
I understood that.
Call medic.
Or call somebody who will
Call
know
Emily.
what they're looking at. Yeah, call
Emily,
Emily, wake
I got
her
it.
up.
But that's,
Hey, you just got off work. Great, I got something for you.
but that's the thing. You've given me scenarios where I'm like, I have no idea what I'm supposed to be doing.
And here's the thing. There are times in this industry that you will take care of a patient and not know what the fuck is going on. You have absolutely no idea what is causing their issue. And you just have to accept that you don't know.
Yeah.
You know, that there will be times that
You
like,
can call medical control, or even as simple as, we got all our numbers on, speed dial. You pick up, you call one of the medics that are at the building, or call the building. Hey, I need somebody, quick, anybody, I don't care. Just
Erica.
get me somebody that, right. I was going to say, I just need somebody that knows,
something more than
I
me.
Yep.
But yeah, at the very end of the day, the best thing you can do, you can't do better than someone starts their name with doctor. So,
I mean, you can.
I was going to say.
There's a few, yeah. But you can pick up the phone, you get a doc on the phone. Hey, and if they sound like they're 15, you go, can I have your attending, please?
Right. Can I have your parent please, on the phone?
Put dad on the phone. Put mom on.
That's what everybody thinks when they talk to me on the phone.
Especially if it's like March. Right. And then you're like, oh, man. Any other further questions, comments, concerns about this one? No, I think we're pretty good. All right. So guys, we will see you in the brand new year. Hopefully it's been better than this one to start out. But we will see you in January when we're going to talk all about humanity in EMS. This was something that came up from a call that I had, and Gerard, this is a big topic that you really pound home, and I think EMS has lost the ability to conduct themselves in humanity of human life. So we're going to have a discussion about it, and that'll be January 1st. So Happy New Year, guys. Merry Christmas. And I will say at first, festive donuts.
Awesome.
Festive donuts.
Better than regular ones.
They're red and green.
And beautiful. Santa
And
Clauses
blue for
elves.
our Jewish listeners.
There you go.
There we go.
All right, guys.
Ooh, they get what, 7 of them?
They do get 7 of them.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.